I would just talk loud.
Okay, I'll turn this on.
Welcome to 2025. We're beginning a new semester. And yes, parking does get easier as the students drop out. Okay, so we're starting today with Kendall Guthrie, who is now a clinical professor. I wish I would have known that I would have updated the last newspaper that we had. And we're here to talk today about safe uses of over-the-counter medications. That's what OTC stands for. Kendall's going to talk for about 20 minutes. Her partner's going to talk for about 20 minutes. If you could hold the whole questions to the end, that would be appreciated. It's all yours.
Thank you. All right. Thank you so much, and thanks for having me today. I hear that this is a lively group, so I'm excited to be in front of you all today and honored that you asked me to come. So I'm Kendall Guthrie, as she mentioned. I'm the Director of Co-Curriculum at the School of Pharmacy, and someone had already asked me, what's co-curriculum? Essentially, it's the extracurricular stuff that our students do. So we know that there's a lot of stuff we can teach them in the classroom, but sometimes they just have to get out and practice those things. And so it's the tracking of that and making sure that all of our students are doing similar types of activities and meeting the same outcomes. So I laughed one time because I got up in presentation and I said, so that's what my that's what my unit does, that's what my office does, and I'm like, I'm an N of one. I have nobody who works with me, so we don't really have an office, but that's what I do. I do the tracking of that. So yeah, I'll start with just some general information about over-the-counter medications, OTC med use. Some of it's going to be pretty basic, and then some of it, some newer information that I'm hoping maybe will be some new information for you as well. And then I'm going to turn it over to my colleague Sydney, who I knew whenever there was, Sydney McQueen right over here, I knew whenever I got asked about supplements, potentially, or vitamins, and I was like, Sydney is our expert resident in that, so we'll jump over to her. So there's a lot of terms that can be thrown about when you start talking about over-the-counter medication, so lots of them just mentioned up here on this slide. So what I'm really going to focus on is more of those traditional OTC meds, and if it's okay with y'all, I'm just going to say OTC from here forward because it saves me some words. And then, like I said, Sydney will jump into some of these others as we go through too. So what is OTC? So OTC, over-the-counter medications, basically anything that's available without a prescription. So what you're getting over-the-counter without a prescription, and generally it's going to be used to treat common or self-limiting conditions. So these are not things that are typically chronic. These are going to be things that are resolving on their own, and we're using medications over-the-counter in order to do so. So just a few statistics as I was going through this. So as many as 300,000 OTC medications marketed in the US. So it was kind of funny to me as I was pulling that stat from the FDA website. They said anywhere from 100,000 to 300,000. Seemed a little odd that was such a wide range, and the OTC or the FDA wasn't really sure where it fits, but so up to 300,000 medications marketed in the United States. 2.9 billion retail trips annually to buy OTCs. The U.S. household, this one I kind of found interesting, spend an average of $338 annually on OTCs, which if you think about, that's the average. So we have people that are going to be far above that. That was a lot higher, honestly, than I was expecting it to be. And then 81% of U.S. adults use OTCs as a first treatment for minor ailments. And then 750,000 retail outlets in the U.S. So interestingly, you do not have to be in a pharmacy. As many of you are aware, to buy an over-the-counter product, you find these things at gas stations, you find these things at retail stores. There doesn't have to be a healthcare provider on a premises to buy an over-the-counter product. So benefits, obviously there's a lot of benefits of OTC medications. So savings to the healthcare system, you'll find different references to how much savings that actually is. But one of the references that was the newest one that I found said about $225 billion. Savings for patients, so specifically looking at patients that maybe have those high deductible plans or have a higher copay to go to an office, to have a provider visit. Or we do have, as we look down below at the accessibility for underserved populations, there is a population of patients that often do use emergency services for their first point of contact, even for some of these more minor ailments. So when you start looking at things like emergency room visits, and that cost obviously can grow very quickly. And then increased workforce productivity. So if they don't have to wait to have a provider visit or to get in with a doctor to see them or get a prescription, then potentially they can get back to work quicker, and we have that increased workforce productivity. And then obviously consumer empowerment. So with over-the-counter medications, people are self-diagnosing, they're self-medicating, they have some choices there. And we'll talk about that because that has some limitations as well. So why is it important? That I'll be honest, this is a slide I use with our students. I teach our over-the-counter medication course at the pharmacy school, and we have a lab, an applied skills lab that goes with that as well. And this is a slide that I use with our students because I often get students coming in with experience with over-the-counter medications, and they think, sometimes I get students that say, why do we have to take this course? They're available over the counter. That means they're safe, right? You can just walk in and buy them. That means they're safe. And so there's a variety of resources, as I'm sure you all know, written and things in the media, social media. The variety of resources with these products is unending. And then people often have personal experiences. So this is where it gets really interesting when you're teaching OTC medications, because it's very rare, I would almost argue never, that you find somebody who has never had an experience with an over-the-counter medication, either themselves or a family member or something. And then the regulatory, marketing, and consumer use process is much different than prescription medications. We'll talk through what that means here in just a little bit, because there's been some big changes of late with this. So non-prescription status, what does it mean to have a non-prescription or OTC status? So consumers have to be able to safely use the product on their own. So they have to be able to safely use the product. That use is guided by a product label. So how many of you have seen the drug facts label that is on every non-prescription? Yes, so that's a requirement. It has to have that label. There's a lot of studies that go into that label and what it has to have on it, because they have to make sure, they do a lot of consumer use studies to make sure by the time it reaches a consumer, they are interpreting those directions like intended on the label. They have to be able, again, to self-diagnose, self-treat, and self-manage their condition, and there needs to be no healthcare provider needed. I would argue that one a little bit, as you may hear throughout the presentation, but essentially, they should be able to do these things based on the product labeling is what it's getting at. Low potential for abuse and misuse. You will notice that doesn't say no potential. We still have some over-the-counter products that have those risks, but lower potential. And the benefits of it being over-the-counter have to outweigh the risks of it being over-the-counter. All right, so safe is a relative term, and I'll talk to you about what some of the reasons for that are. So we do oftentimes with patients, in our pharmacies, see that there is this mindset of, because it's available over the counter, it's safe. There's no risk, it's been studied more, or whatever the feeling is with that. And I would say safe is a relative term. So when you're looking at a non-prescription product, and you're looking at what it's intended to be used for, and there's warnings on there and the dosing, that's not exactly taking into consideration some of the unique disease states, medications that people are taking. So obviously it's kind of meant, when they make those labels, it's kind of meant for somebody that doesn't have any interacting medications, doesn't have any other disease states that could potentially interact with that medication. We'll talk through some of those. So I would say safe is a relative term, and we'll talk through what I mean. So as I talk through this, I'm not going to go into detail on this because this could be a whole talk in and of itself, but it's, I think, very eye-opening when you start looking at over-the-counter regulation. So we've had a lot of different regulatory, legislative rules that have gone into making the process what it is. So we've had acts that it really wasn't until 1938 that we even had to start saying these products are safe to be over the counter. So anything before that, we really didn't have to say it's safe for you to use. We had amendments that actually made the non-prescription status of medication. So it used to be kind of confusing because manufacturers could say, I want this to be over the counter, and another manufacturer could say, I want this to be prescription, and there really weren't a lot of guidelines about what that looked like. So we had amendments that actually formed those two classes of different types of products. We had an amendment in 1962 that actually said products had to be effective. So up until that point, they really didn't have to prove that it actually worked, right? It had to be safe if you took it, but didn't really have to work for what they were saying it had to work for. And it wasn't actually, which this is just kind of mind-blowing to me when you think about it, it wasn't until 1972 that the FDA actually came up with a drug review process. And at that point, for over-the-counter medications, and at that point is when they said, okay, we're going to start looking at all of the medications that have been approved from this point forward and see, do they actually meet our safety and efficacy requirements? And what's interesting about that, it's called the monograph process. The monograph process is essentially a recipe book. So if you want to market a product in the United States, an over-the-counter product, you have to market it exactly as said by this recipe book. If you don't, you have to file a new drug application with the FDA, which is just a more laborious process. There's a lot more steps to it. So essentially they're saying, as long as you follow our recipe book, you can market these drugs in the United States without going through all of these other loopholes that you do with a new drug. So what happened in 2020 with the CARES Act, so there's a little something, I don't know if you've heard of it, that we had a pandemic that might be new news. A lot of people haven't heard of it, but in 2020 we had something called the CARES Act. And what part of that was, is they said, okay, we have all of these monographs from back in the 1970s, these recipe books that we're supposed to be using to market these drugs. A lot of them still weren't finalized. So at the point of 2020, a lot of them still were these tentative. So there were a lot of things on the market that hadn't really been determined if they were safe or effective. A lot of the manufacturers were actually using kind of those tentative monographs, but the FDA didn't have a lot of regulatory authority at that point to enforce a lot of that because they were still in this tentative. So what the 2020 CARES Act said is that those had to be finalized. So they actually had to finalize those recipe books. And I'll talk about some of that here in just a second. So and I'm just checking my time because I tend to start talking and then I go over, so we're still good. Prior to the CARES Act, many of those monographs, again, remained unfinalized. The CARES Act essentially froze the status quo. So it took those tentative monographs and it said, okay, we're going to go ahead and say these are finalized because they never were finalized. That gave the FDA some regulatory authority. But many of the monographs still included outdated science. So now they're working to, okay, we have all these finalized, so we have some regulatory authorities. Now we're working to amend those to reflect current science. And I'll give you a couple of examples. So there's a sunscreen monograph. So the sunscreen monograph actually includes 16 ingredients that are safe and effective. Have any of you seen anything in the news about sunscreens? There's been things about harming coral reefs, and certain states and locations have banned certain ingredients, things like that. So there's obviously been a lot more interest in the safety of sunscreen ingredients. A lot of those, well, all of those sunscreen ingredients are currently recognized as safe and effective in the finalized monograph. But what they did, so in 2020 with that CARES Act, they went ahead and finalized it and said, okay, based on the information we have, we're going to go ahead and say those 16. But then they immediately, the same day, published an updated monograph and to include some of those. In the updated monograph, only 2 of those 16 ingredients are recognized as safe and effective. 2 of those ingredients are not safe and effective because they found that they're actually causing some pretty significant adverse events for people and side effects for people, so safety concerns. And then 12 of those ingredients, which are a lot of the ones you see in the news for coral reefs and things like that, they're saying, we're not saying it's not safe and effective, but we're not saying it is. We really need more data. So it's just interesting how big of a difference it was between the two, and that's just kind of where we stand right now. We're waiting on that monograph to then get finalized. So you still see a lot of those sunscreen products out on the shelves. I'll be honest, I have 2 little girls, 8 and 4, and so I teach the sunscreen section for our students, and trying to find sunscreen products that only have those 2 ingredients that have been deemed safe and effective is kind of challenging. And so I think as that gets finalized, we may see some big changes in the sunscreen marketing, in the sunscreen market. Cough, cold, and allergy products. So that was another one. So again, in 2020, with that CARES Act, they went ahead and finalized that recipe book and said, okay, we're going to go ahead and finalize this. It's been in process for quite a while. Pretty immediately after that, the FDA convened and they found that one of our common decongestants, so I don't know how many of you have ever gone in for a cold, and you either get something behind the counter that you have to show your driver's license for, so Sudafed, or there's some products over the counter that have an ingredient called phenylephrine, and those are kind of our big 2 decongestants. They said phenylephrine isn't effective, doesn't do anything, but it's still in the monograph right now, and so they're currently working on updating that monograph as well. So you'll still find phenylephrine on the shelves because it's technically not in the monograph yet that it's not effective, but they're saying it's not effective. So you can see there's some gaps here, right? There's some gaps between what we know and what the legislative authorities and regulatory authorities show. OTCs are still associated with misuse, abuse, drug-drug interactions. Apparently I really wanted you to know about the interactions because I said it twice, drug-drug interactions. And then drug-disease interactions, they can have toxicity. So we see inadvertent overdoses of over-the-counter medications, adverse effects, even hospitalizations and death as well. I'm just watching my time. So I won't go through these in detail. This is another study that I pull for our students, again, just to show them the value that they bring as a healthcare provider to over-the-counter medications. A lot of words here, but essentially there was a study done in pediatric patients where they looked at cough, cold, allergy products. And of the almost 5,000 cases that had an adverse event from one of those products, 513 of them were due to a medication error. So about 10% of you can have adverse effects, right? A side effect is an adverse effect. We expect some of those, but about 10%, 11% of those were due to an actual error. When you looked at those errors, many of those events actually were incorrect administration by a parent or caregiver, such as administering the wrong dose, and about 75% of them required healthcare facility evaluation. So pretty significant errors and events that were happening from an over-the-counter product. I'll skip this one. This just shows exactly where, just for the sake of time, where these individuals were being treated for those adverse events. And then this is all of the different types of adverse events or errors that those patients were exposed to. So things like wrong timing of dosing, but also using multiple products with the same ingredient. So 2 different cough cold products maybe had the same ingredient and they didn't realize. So a lot of different errors that they captured in this study. When you start looking at older adults, you look at, as you have increasing age, not always, but often that comes with more medical conditions and more medications. And so our older adults are at high risk because they actually use about 30% of over-the-counters on the market. So I think the study I had looked at said about 17% of the population is what they account for, but they are using about 30% of over-the-counters, and about half of them use over-the-counters daily or weekly. And then one fascinating statistic was NSAID use results in about 80,000 preventable adverse drug events. So this is things like ibuprofen, that's aspirin, things like that are really common. And then there was a recent study that showed that nearly 80% of older adults demonstrated probable OTC misuse in the study population that they were capturing. So what are some ways, and I'll go through these really quickly and then I'm going to turn it over to Sydney. So what are some ways that you can increase OTC medication safety knowing these things? So always talking to a doctor or pharmacist, especially when you're starting a new medication, because it could interact with other medications. It could be unsafe if you have certain medical conditions. So always making sure to talk to somebody, especially when starting or stopping, and making sure you understand the label directions. Is how you're interpreting the label instructions exactly how it was intended to be taken. Reading the label, so not only knowing active ingredients, but inactive ingredients. Look at those warnings. That can help you determine if maybe you have a condition that doesn't do well with that medication that you're selecting. And then again, those directions. And those directions may differ than prescription directions. So maybe you got an ibuprofen before from a doctor, and the directions, the frequency that you're supposed to take it or the dosage was higher. And that happens. Sometimes we have things approved as both a prescription and non-prescription product, but the dosing on the label is what has been determined to be safe dosing for self-use. That's the label and what that looks like. And then using correct measuring tools. So I thought this was really interesting, especially with this group I'm presenting to. I feel the need to tell you I have no permission to use this picture, but I wanted to make sure I showed it to you because I thought it was really eye-opening. In this study that they looked at different types of household spoons and how much volume they actually had. And so you can see right here that row listed volume, how much actually liquid fit into each of those. And so we have a lot of variation in our house. So actually using measuring devices, syringes, things like that, either that come with the product or that you are provided for at the pharmacy. And then watch out for duplicates. So these ingredients listed here are often found in many different products. This is the typical brand name. That doesn't mean it's the only brand name that has those products. So for the sake of time, I'll just tell you, I was gonna have you all guess. Well, I'll have you guess. How many of these do you think have acetaminophen or Tylenol in there?
All.
They all do, yeah. So all of these different brand names have Tylenol, and that's what we see oftentimes is people don't realize that the different products they're taking have Tylenol, and you can get to that Tylenol kind of overdosage limit pretty quickly. And then watching brand names. So this is just an example. This is the Mucinex family of products, which Mucinex, kind of people generally think of that expectorant that kind of breaks down the mucus, that you have when you have a cold or something like that. But they have a whole line of products. And so really paying attention to ingredients, not just relying on a brand name, is really helpful. All right, and I'll save that for the end. I'll turn it over to Sydney, and then maybe both of us can take questions at the end.
So I'm Sydney McQueen with the School of Pharmacy, also a UMKC alum, so I kind of stayed here since I very first started. So the first section that I'm going to talk about with the vitamins really has a lot of overlap with the OTC drugs that Kendall was talking about. The dietary supplements and the CBD that I'll be mentioning really gets into this area of it's legally different. Okay, so we'll so dietary supplements, that terminology was actually created in 1994 when the Dietary Supplement Health and Education Act was passed. It really fits in with that previous slide on regulations right between the 1972 and the 2020 there. And it created this idea of dietary supplements. So you'll see things both ways, and they'll say, "Oh, dietary supplements are not FDA regulated." They are, just not really tightly. Okay, they don't have to be proven to be safe and effective before being sold in the marketplace. Okay, but if there's proof that comes out that they are unsafe when used as directed, the FDA does have the authority to say, no, you can't sell that. So far it's happened once. A lot of people unfortunately had to die before it took 20 years to get some of the ephedrine alkaloids off the market that were being sold. So, all right, that's regulation stuff. So what are these dietary supplements? Generally, we want to use vitamins and supplements as prevention. Okay, we want to prevent lifestyle-associated diseases, disease state, or medication-associated. Yes, healthcare providers can cause you problems because of the medications that we dispense. Because because some of those have little side effects of decreasing the nutrients in the body. But usually it's an easy fix to replace those. Okay, so if in general we think of nutrients, people who are at risk of deficiency or insufficiency, not taking in enough because of not eating a proper diet, something wrong in the gut where we're not absorbing it as well. For some reason there are increased requirements, such as when a woman is pregnant, right? Nutrient requirements go way up, calorie requirements go way up. We can be depleted because our bodies are excreting them more, have more need, and then of course the medication issues. So what am I talking about when deficiency, insufficiency, all of that? I'm big into analogies. I like to think with that. So you hear about these ideas of you can optimize your energy levels. You can optimize your nutrient, your vitamin levels. That's like a concept car. It does not exist, except in the minds of the engineers who create it. So that's advertising. Ignore it. There's sufficient, which is where we want to be. It's like a car that gets you where you're going to go. It's not really going to break down very often, things like this. Insufficient. There's some issues. We're still going to be able to travel, but maybe not as efficiently as we would like to. We'll have some problems along the way. That's like when you're insufficient in your vitamin levels. You might be beginning to get some symptoms or develop a disease state because of that, but you're still operating. Deficient, you're going to have some sort of disease. some sort of presentations happening with that. And that's when those vitamin levels are so low. One more nutrient state that's not on here, and that is toxic. Toxicity with vitamins happens because people think vitamins are totally safe. Just like the what you said about the OTC medications. Oh, it's over the counter, it's got to be safe. It's like, not necessarily. And the idea that more is always better. It's like, not true. Even for water, you can, people can poison themselves with too much water, just like with everything else. Advertising for these products really hits on a lot of our emotional motivations for wanting to take good care of ourselves. And, maybe it's, I want to avoid going to the doctor. I want to take good care of myself. That's a good motivation. But, the idea that maybe our standard Western medicine hasn't been able to solve all my problems. I want to see what else I can do to support my health. Okay. People who, a lot of advertising, which I really hate to see, is, when maybe we're out of options. People with terminal cancer or other terminal disease states are hit by these advertisers and say, oh no, we can help you, when that actually isn't true. The idea of you can get acetaminophen in so many of these over-the-counter products, same sort of things come up all the time with products that have the same ingredients in them. We see this a lot with antioxidants. So vitamin E, vitamin A, vitamin C will turn up in something that somebody is taking for eye health or heart health, or cognitive health, something that's supposed to help memory, things like that. And people can get toxic because they're getting this nutrient excessively because it's coming in a lot of places. All right, so next up, multivitamin minerals. Your standard multivitamin. Most of us probably don't take the chewable Flintstones anymore, despite the fact that they tasted really good. And a lot of argument to this is like, well, isn't it better to get our nutrients from fresh food, fruits, vegetables? Absolutely. Yep. Yeah, always better to get your nutrients from real food. Okay. Nobody eats a perfect diet. I think it's impossible in this world at this time. We can do really well, but nobody eats a perfect diet. So this is a way of getting insurance for ourselves. The other thing is that so many of our prescription drugs will affect one or more nutrients in the body, causing increased elimination, causing our bodies to need more, interfering with absorption of nutrients for whatever reason. That basically, I teach our students that if someone's on a prescription drug, they need to be on a multivitamin. Okay, multivitamin and mineral. Not all vitamins have minerals in them. Because when I look at all the data, the different studies that have been run on medications and then the individual nutrients, and how much do we have to take of that nutrient to offset the damage? What's in a multivitamin is enough. Okay, and rare exceptions to that, of course, but that's pretty standard. So, okay. Generally, we would look at what we call the RDA or the DRI. Our language terminology has changed over the years, but daily recommended allowance, daily recommended intake, however it's listed on that nutrition facts panel that was mentioned. 50 to 150%. Something in there is going to be a good number, but there are exceptions, of course. B vitamins, you'll often see what look like scary high percentages. They can be 1,000, 2,000. It's like, seriously? Like, it's okay. They're water soluble. Generally, excess does get flushed out of the body, and there are sometimes reasons to have more of those B vitamins. Okay? Their individuals sometimes have increased needs for things. For example, people who smoke need to get a minimum of 100 milligrams of vitamin C a day. Okay? And most multivitamins will not include that much, so that means a separate supplement. There are multivitamins that are designed for adults and then for older adults, because there are changes that we go through as we age. One, our need for iron goes down. Okay? We generally need higher amounts of vitamin B12. B12 is absorbed in the stomach as we age. The intrinsic factor in our stomach that helps us absorb the B12 just naturally declines, and so we need extra to be able to absorb that. Or we get to the point of getting B12 shots at the physician's office. Vitamin D requirements go up, and generally these what we call silver multivitamins are going to have higher calcium in there as well. Although that's one of those things, that calcium is such a big, it's big. It's a big molecule, and molecule size, but we need so much of it that you can't put all the calcium that's needed into one pill, or sometimes into 2 pills, so that's generally done as a separate supplement. Gummies are everywhere anymore. It's like they're putting everything into gummy formulations. The problem with that is that the minerals don't play well with the dosage form. Okay, they can interfere with some of the gelling process, so that a lot of times the manufacturers, it's like, oh, we won't put as much iron in there, we won't put as much potassium in there or whatever. So the gummy formulations for multivitamins often do not have what's really needed. So we generally tell folks, just ignore those. Okay. We also recommend that additional ingredients like amino acids, herbs, other nutrients, there's really no need to have those in a multivitamin, with a few exceptions. The biggest reason is that even if it is something that has been shown to be effective, the amounts that are included in the multivitamins are usually so low that it's negligible. It's not enough in there to really make a difference. Okay. And usually the labeling will say if something is regular silver, it'll say for over 50, something like that. And a lot of times they have silver labels. Okay. So let's talk for a second about some single vitamins and minerals. Vitamin D has really been interesting over the last, say, 15 years or so, because that's it. Well, I can talk quick. It was believed to be that we had a pandemic of people being deficient in vitamin D. Okay, they raised the limits. Okay, from the recommendations from the government, and then they started saying, oh, we've got people overdosing on vitamin D, and this was after all the manufacturers had really increased, so those have come down now. Yes, we need more vitamin D than we get usually, but it's not as much as what the advertisers are going to tell you. Fortunately, this is one that, it's fat soluble vitamin. You don't have to take it every day. Get outside, get your sunshine, have it made, and then, a reasonable amount. Okay? We don't want to see people generally doing over 1,000 a day. Okay? Calcium, all the women in the room, are you taking your calcium? We all need to. This is just one that shows basically plain old calcium carbonate, the cheapest kind, generally going to be the best for most people. Okay. For those who have that causing tummy troubles or constipation, going to the citrate form is a good option. And if anybody's on something that lowers their stomach acid, then taking a citrate form is good. B vitamins get really confusing. In general, it's a good idea if there is a need for extra B vitamins, except for vitamin B12, okay, to take a B complex instead. And this is an example of, I went out and looked at stuff on the shelves and got a big range. You'll see something like a B50 complex or a B100 complex. That's usually going to be a better bet than taking a bunch of individual B vitamins. The exception to that is B12. If anybody's on metformin, that's one of our drugs that's like, yep, need to have some additional stuff. All right, I'm going to skip a couple of things. In multivitamins, these are 3 that are very commonly added. They are usually present in doses that are too low to be of much use, except for lycopene. And that's generally one that we can get from food. If one is needed for eye health, especially with lutein, good idea to take a separate supplement. It's also cheaper to do a separate supplement of lutein plus a good multivitamin than it is to do the fancy AirEd's vitamins or things like that that come up in the advertising a lot. Okay, CoQ10, good for heart failure. A lot of the side effects that are associated with statin drugs to lower cholesterol are actually believed to be associated with or caused by the lowering of CoQ10 in the body that the statin is responsible for. Okay, so this is one of those where it's like, all right, if you're prescribed a statin, probably not a bad idea to start taking CoQ10 along with it, especially if one starts experiencing side effects. It doesn't always work to add that to it, but sometimes it really does. Makes it possible for people to stay on their statins. How much time do I need? Can I take one more minute? I want to mention one thing about CBD, which we've got a lot of people are interested in CBD. If anybody is being treated for glaucoma or is going to have cataract surgery where they may have a short-term elevation of intraocular eye pressure, super common after surgery, no CBD. Okay. This is one of those things where medical cannabis has been shown to lower intraocular eye pressure. It does it about as well as the prescription drugs do. That's the THC component. CBD alone has the opposite effect. So anybody needs to avoid CBD if they have elevated eye pressure. Okay. All right, I'm so sorry I ran over time, but let's go on to questions. So,
You know, one of the things that strikes me, maybe without getting into specifics, is the fact that there's a number of things that I heard for the first time today.
Yep.
And I'm a dentist, and I'm not saying that to brag. It is what it is. But some of these things I didn't know, which I should have known, perhaps, never heard them. And the other thing is that how many of these drugs, for instance, cholesterol-reducing drugs, how many of those prescriptions do you think go out on a daily basis, and there's never a discussion in a physician's office about the importance of supplementing with CoQ10 with that? And I personally experienced that bone achiness from taking statins. I never was given that suggestion, ever. So, and the others is the gummies with kids' vitamins.
do you think pediatricians tell parents that? I mean, you know, I think, and I understand the busyness problem, but I guess I'm just shocked that some of those common things are not discussed in physicians' offices who are actually giving the prescription for the item.
Yeah, well,
It's more of a comment than a question,
Yeah.
but I guess it's shocking.
I think it's a valid comment.
It's shocking. that
So
those
do
things
you
are not
teach your
discussed.
course on vitamins and things like that and over the counter to medical doctors in training or only to your pharmacists?
We are only pharmacists.
No.
only the pharmacy students. Unless you teach that, I don't know.
I actually teach dental students one lecture on herbal supplements.
That's great.
Talk a little bit about them, so.
I do think to your point though, some of this is willingness and ability to keep up with the data as new things come out. I do think something we just didn't have time, honestly, to cover all of this. There can be a stigma with supplements and natural products, herbals, those types of things. And so I think there is some people that just, I'm not recommending those types of products and don't do necessarily the digging needed or the research needed to, and we would both stand up here and be the ones to tell you not every product we would recommend. Now, there are some that we think are better than others or some that we would recommend. And so I think it just takes the ability to dig a little bit deeper, and some people just don't take the time to do that.
Well, and the other thing is, you know, in today's system of medicine, physicians have, 12 minutes per patient or something? And that may be one of the reasons why a lot of things don't get covered.
Yeah. Yes, Dr. Baines.
So, one of the questions that I have is, well, a couple of, so I was prescribed iron this year, and I went to my CVS pharmacy and talked with the pharmacist there, a former student of mine, who I talked to him about some of the other drugs I was on, and he's like, well, you shouldn't, because of this drug, you need to take the iron at a different time than when you're taking that drug. So,
Good.
yeah, so my first question is, when you go to a pharmacy, the pharmacist behind the counter, how much are they keeping up with what's going on to be able to be giving me good advice about things like dosages and timing and I'm sure drug interactions are not a big deal because they can go to the computer and say, oh, you're on this drug, and these things would interfere with it.
I can start, and then if you want to jump in. So from a continuing education perspective, pharmacists are required. We are one of the health professions that's required to have continuing education. Now, it's not specified that you have to do so many hours in these content areas. Now, to your point about drug interactions, I would say that anytime, especially as you start adding medications to your regimen, so even if you only have a couple of medications that you're taking, anytime that you start taking a new medication or even are going to take an over-the-counter medication, I would recommend doing an interaction check or having your pharmacist do an interaction check, because even if you can go online and you can run a quick interaction check, if you look at those reports, there's different levels of interactions, and some of them, quite honestly, like I look at it and I'm like, I'm not worried about that at all. That's not clinically significant, and then other ones are, and that would be for a lay person, that would be I think very difficult to distinguish. And so that is something that we train our pharmacy students on, is evidence-based medicine. How do we look at these reports and figure out, okay, what is actually significant for this patient in front of me? I don't know if you have any other comments.
And something specifically like about the iron, that would be something that they would have learned in their basic pharmacology classes, about iron has an interaction with this drug, and here's how you deal with its separation in time. So there's a lot of that sort of thing. Getting a little more involved in, like the idea, I had a slide up about 2 different types of iron. That kind of thing, when it would be like on them to be keeping up with the latest data about, well, now we do have data to support iron bisglycinate instead of just ferrous sulfate or something like that. Is every single pharmacist going to know the difference at the same time? No, it's going to take some of the months and differences of the continuing education to get there.
I have
Well, and sort of along that line, so with multivitamins, if you're taking a multivitamin, is there a time of day or with or without food that makes a difference in how effective that is?
Can I add one other comment to your first question before we get to that one? The other thing I was going to recommend, and don't get me started on insurance and insurance limit. That would be a whole, if you want me to come back and talk about that, you let me know, because I have a lot to say about that. But, so this isn't always the case. This isn't always going to be a possibility. I would recommend, if possible, filling all of your medications at one pharmacy. That's not always possible, because if you get certain types of medications, they make you send them to certain there's different reasons why you can't do that. But the reason I say that, to your drug interaction point, is if you are getting all of your medications at the same pharmacy, the computer system runs a report every time a prescription is filled. And so those things should be getting looked at in the dispensing workflow before you actually get your prescription. That also makes it a lot easier if you have an over-the-counter herbal supplement for them to do a quick interaction, because they have all your medications right there as well. And then did you have a comment about the multivitamin?
Yeah, just it depends on if there's an interaction there with medications. A lot of times there's not a problem with taking them, everything in the morning when it's right. If sometimes though, when there is, even if it's minor, how important is that drug to your health? You may want to be taking the multivitamin, at lunchtime, when the rest of your prescription medications are in the morning or at night, something like that. And there are times when, you're getting, by taking your fiber and your calcium at the same time, you're going to get a little less absorption of your calcium. Are you still going to get benefit from it? Yes. Does it make it easier for your life to take them at the same time? Yep. Yes. Go ahead and do it. Because there are times when we've got drugs where the dose is really tiny, a little bit of a change in absorption is important, and there's usually quite a bit of education on that if that's the case. But for nutrients, we've got wiggle room, so we don't worry about a day-to-day slight difference in dosing like we do with medications.
I am having a full circle moment. I went to UMKC here. Dr. Boehm, I took biochemistry with Dr. Boehm, and I'm sitting here thinking, I just got asked a question by Dr. Boehm during the presentation. This is pretty cool.
Well, I told my husband when I left, I said, I'm pretty sure Kendall was a former student of mine, but it's been a while.
Yes, I got swine flu during one of your exams, and you were so kind to me, and I will never forget it. So, Peggy, did you have a question?
One last maybe comment. And I'm a nurse, and we teach nursing students. We always make fun of the commercial that says clinical studies have shown. That means some people took it and some people feel better about it. And it just bothers me when I see patients and families come in and they're on all these things that make no difference at all. Prevagen is my pet peeve. There's been so many lawsuits against that. It doesn't do anything, yet you ask a group of over 50-year-old people, and a ton of them are on it, and it's expensive. Yeah. Could the pharmacists do pharmacists? I mean, I know we don't even ask. My pharmacist doesn't even ask me if I'm taking anything over the counter. We pretty much talk about what I'm on. But how do we start to tag that stuff that's just mean? I mean, it's sapping their money away. It does no good at all. And it's not just, I guess Prevagen's my pet peeve. What's your take on crap?
So I'm going to go off track for just a second because I feel I need to comment. So one of my jobs, I've worked in several different practice settings, but one of them is I would go up and do educations on patients who were going home after having a heart attack and all the medications that they were on. And I remember there was one time that I looked in the patient's chart and it said she was on no other medications, and went and talked to her. And after talking with her, she didn't see the medication she was on as medication, so she didn't tell anybody, and no one probed further. And after talking with her, she was on 32 over-the-counter medications and supplements with several significant interactions with what she was going home on. And so to your point, I think that there is a big education issue oftentimes with, there's a gap, right? And then it looked like you were shaking your head with Prevagen, so I'll let you comment on that.
Yeah, totally agree with that one. But that is one thing that we are doing, is we are training our students when they are taking a history. It's what medications are you on? What over-the-counter medications are you on?
Absolutely.
What supplements and other things are you on? And I think we're being much more successful in that, because when we do the OSCEs and, you know, the role-playing examinations and things, the students are all asking that. And all the pharmacists who are out there on the front lines doing the dispensing need to be asking more of those questions, at least on a regular basis, you know. It comes down to time, I think, and
There are, and to your point as well, there are groups that have taken a hold of that idea. So the Consumer Health Product Association has these huge campaigns that they're doing. Like one of them is on the dosing, like the spoons I showed you that I didn't have approval to share the image, but I wanted to. That picture, they're doing a whole campaign on that. And so there are, I feel like, associations that are latching onto some of these safety issues and their whole job is getting it out to consumers. How do we get this safety information out to consumers? And they work with pharmacy schools as well on those campaigns to say, okay, we got the consumer side covered. Can you all help with the provider side of these? And so to issues like that one, I think they're working on some of that as well.
I think you were trying to
Yes,
ask a question.
yes.
Yeah.
According to my doctor, he told me that all the nutrients and the supplements and the vitamins are not really useful, because according to what we eat today, we don't need that. And the other point is that beyond all the medications, please don't drink, don't smoke, don't do drugs, don't gamble in the casino. All that are important. All that are important. You can have all the medication you want, but you are destroying your whole organism.
Yeah.
So
We need sleep, we need proper food, we need
the
exercise.
point is there. I mean, you know, I'm 75, and what I do, I take my Zyrtec every night, and in the morning Flonase. I've been done that for 15 years. I never had any kind of cold. My COVID, I had COVID. I didn't perceive it. The doctor said, "You got a COVID." Oh wow, good to know. But I didn't have any. But yes, I'm taking nutrients, vitamins, and supplements, all these things. The point is, well, just let's try to be humanist. Humanism is important because we need to live our lives according to some kind of moderation precepts, and everything is there. And forget about, yes, the pharmacy. I go to the pharmacy. I have many medication at home. But the other point also important, excuse me, I'm optimistic, which means that I know that if I buy something, maybe it's working for everyone, but not for me. So what you buy, it's not the universal panacea, which means it's good for everyone. No. You need just to know and understand and listen to your body to exactly see what you need about that. And that's it.
Yeah, no, I totally agree. For those online, there were, I'm going to paraphrase, some comments about a physician potentially having some hesitancies about supplements and vitamins, because saying that we get all of that in our diet, but also the importance of moderation and not smoking and not drinking, and I think you said not going to the casinos, so other lifestyle. So I'll comment on a couple and then I can pass over to Sydney because I'm sure she has thoughts as well. But one of those, I think I would agree with your physician that if we were eating the way that we were supposed to be eating and had those foods available to us, I think is the other side of that. I would agree that you're probably covering yourself. I'll speak for myself. I know what I'm supposed to eat, and I still eat like crap sometimes. I have 2 girls who eat chicken nuggets because it's all that they will eat. I know that they're not getting their nutrients, but it's that or starve. And people tell me they won't starve themselves, and yes, they will. I guarantee they will starve themselves before they'll eat something that they don't want. So I think it's just a matter of, are you actually eating those things, and can you get the foods? Because if you look at some of our underserved populations and what they can afford to eat, they likely oftentimes cannot afford the food that they would need to get all of their vitamins and nutrients as well. And so I do think that I agree to the extent if you could do it, that maybe there wouldn't be a need for supplementation sometimes, but I don't think many of us can say that we do that all the time. But I also agree with your moderation comments as well, and I'm going to pass to Sydney.
You know, one of the things I think that we have a problem with is that with especially the herbal supplements, that we see people taking things, and if you ask them, well, why are you taking this? Well, my neighbor took it and said it really worked well for her. Well, do you have the same problem? It's like, no. It's like, well, then you don't, you know, and thinking of these things, we need to think of them like medicines. And it's like, you don't take it to treat something you don't have. And that would get rid of a lot of problems if we could just have people adopt this attitude a little more, that it's like, yes, the chemicals in these supplements, in these plants, in these herbs, are drugs, and we need to think of them like that and only use them when they are needed. I think that would solve quite a few problems.
Yeah.
And avoid the whole toxicity to the pocketbook. That's my reaction to the Prevagen.
Yeah.
And some of these other things is that, you know, people, because of their, whatever their motivations are for, you know, last ditch hope, or the idea that they can achieve optimum wellness, that they are willing to pay a whole lot of money for things that don't work, or haven't been shown to work, or are actually harmful. And that's a shame. And that's one of my goals, is to get people not to do that.
I have the argument with my wife. I take a multivitamin every day, and I have metformin. I didn't know CoQ would be one to consider. But she always says, you don't need a multivitamin because you get it in all the things in the trace amounts in your food anyway. And I say, I don't think I do, despite the fact that we eat quite diverse and fresh and things like that. I have no other arguments to say that, hey, I know what certain cofactors are in biochemical processes, and if I have a couple of more cobalt molecules in there so that my enzymes work better, I think I'm better off. I'm not sure whether it actually makes a difference, but
Yeah.
to have it, the argument, if it comes out of the food, it's better than if it comes out of the pill.
Yeah, and it's, there are actually a couple of instances where that's actually not true. That folic acid
Yeah.
is better absorbed in dietary supplement form than it is actually pulled from a lot of foods. But yeah, and so with the metformin, and like you say, and that's B12. The
B12.
Metformin,
Yeah.
it really interferes with B12. And what I see happening a lot is that this is known, it's been known for a long time, and so physicians will monitor B12 levels for their patients who are on metformin. And
Mine doesn't.
if the B12 levels drop, they will recommend that they start a B12 supplement, get them on B12 shots. And I guess I try to think of it as more preventative. It's like, why wait till we have a problem when we can prevent the problem? And that's why taking the extra B12 when anyone is on metformin, you can avoid problems in the first place, you know. Just a difference in attitude, I think. So thinking about those.
Yes? Oh, I don't have anything to add. Nope, that was great. Yeah.
Yeah, some over-counter medications were prescription medications before. Is that correct?
Yep.
Okay, so if so, under what condition those prescription medication will be converted to over-counter medication, or do we need to pay special attention on those medications?
No, that's a great question. So for those online, I've been forgetting to kind of do this as we've gone. But for those online, the question was about prescription medications that have gone over-the-counter status and kind of what that process looks like. And so yes, when a manufacturer markets a drug, they can either market it as a prescription product, or they can try to say this is safe enough to be an over-the-counter product. Sometimes things are originally approved as a prescription product, and then with time and those use studies where we actually see how people use these in practice and we gather more of that data, following the initial approval, we find out that it's actually pretty safe, and we know with the stipulations that we talked about, so the drug facts label and the instructions and the dosing, that people can actually use them safely at home, and so it'll be converted. Now, sometimes it's not completely converted to non-prescription status. So like the ibuprofen that I talked about earlier, they have found that at higher dosages, ibuprofen has a lot of potentially harmful effects. So it can affect your kidneys, it can affect your heart, things like that. And so at those lower dosages, though, they have found that it can be safely used over the counter. And so sometimes there will be stipulations as far as like dose and things like that. But yes, they have to go through, they can't just decide, okay, it's going to be non-prescription. They have to actually prove that it's safe and effective. And again, there's that additional requirement of having those use studies where they have individuals that look at the label and actually interpret the label and say how they would use it. And so they have to make sure it would actually be used as intended. Yeah.
Under the current administration, how much does FDA keep on doing the things right, and what are they throwing out which will be harmful to us?
Yeah, on that note, it has been really nice talking. No, I'm just kidding. Do you want to tackle that one? I mean, I have some thought. I mean, the FDA isn't exactly now where we are really. So those online, the question was about in the current administration, and is the FDA continuing to do these things that we're talking about today? I think from our area, the biggest impact that we're seeing is with vaccinations right now, and some of the changes with the CDC and the ACIP, which Advisory Committee on Immunization Practices, is kind of where we're feeling the biggest. I actually feel like we've made some pretty substantial improvements as far as the FDA process with non-prescription medications. The fact that all of these monographs from 50 plus years that hadn't been finalized have been finalized, and they're kind of working towards. The other thing I didn't talk about that they've done is that they have made the process easier to amend a monograph, so we don't have to wait 50 years for something to get updated.
They're not throwing them out at the moment.
Not that I am necessarily aware of.
Yeah, as far as the process for the FDA to look at research and approve new drugs going on the market, that is a long-term, complex process, a lot of rules, lots of data needed. It's kind of like, how fast can you turn the ocean liner? So, not very fast. So I think that the stability of that process that is already there, it would take a little bit more to really mess that up than just a few wild comments or something. So yeah, for right now, as far as that basic process of approval of new drugs getting on the marketplace, things like that.
How about drugs and, well, acetaminophen has been in the news lately because there are people claiming that it can cause autism. And to my knowledge, there is very little scientific information that correlates acetaminophen usage in pregnancy with autism. Is it the FDA that would be the organization that would now stick a label on that says pregnant women shouldn't take acetaminophen?
Yeah, if they found something, after, because there's always post-marketing surveillance that's being done, and different programs like MedWatch that people submit these adverse reactions to, if they ever found something that truly had a causal link to it, then the FDA would look at things like black box warnings, which are on several medications that say, you know, what those stipulations are. In the case of acetaminophen, if something like that truly were found, I would imagine that it would be a whole issue of, should this actually be a non-prescription medication at that point, or should we convert to like a prescription status? But again, no actual causal link. And that one, with the link to autism and some of those more, the neuropsychiatric type things, we see that quite a bit, that those claims are made. But to your point, we haven't seen anything definitive.
Yeah, no data to support.
Okay, we will keep you well after this.
Thank you so much for having us. This was a blast. Yeah, I appreciate it.
Right.
Thank you very much.